we are going to talk about an organ that I honestly think has the worst PR team in the entire human body.
Which one is that?
The kidney. I mean, think about it. If I ask you about the heart, you think about romance, vitality, the drumbeat of life.
Sure.
The brain, intellect, consciousness, everything that makes us who we are. But the kidney, we think about plumbing.
Right. Waste disposal.
Exactly. It's the janitor of the body. Useful, for sure, but you don't really want to think about it too much.
That is a painfully accurate assessment of how most people view it.
Yeah.
And it's completely wrong.
That is exactly why I wanted to tackle this specific source material today. We're looking at Chapter 32 of a medical physiology text, and it's all about diuretics and kidney diseases. And let me tell you, after reading this, my view has shifted from janitor to, I don't know, master chemist.
Master chemist is good. I like that. I often think of the kidney as maybe a high-frequency trading computer.
How so? A trading computer?
Well, a filter, which is the common analogy, is passive. You pour coffee through it, the grounds stay, the liquid goes. Simple.
Right.
But the kidney is making millions of split-second decisions. It's constantly monitoring the blood and deciding, keep this sodium molecule, dump this potassium ion, hold on to this water, release this acid. It's an active high-energy process. It regulates your blood pressure, your blood volume, your body's pH balance. And this was the part that really blew my mind when I first learned it. It even dictates how strong your bones are.
The bone connection is wild, and we are definitely going to get there. But we have a specific mission today. This text covers 3 massive areas. First, the pharmacological toolkit, how doctors can actually hack the kidney with diuretics.
Right, how we manipulate the system.
Second, acute kidney injury, what happens when the whole system just crashes suddenly. And third, the slow, tragic decline of chronic kidney disease.
It really is a journey from how the system works to how we manipulate it to, well, how it dies.
So let's start with the manipulation. Diuretics.
A staple of modern medicine. Absolutely essential.
Right. And I think if you stop someone on the street and ask what a diuretic is, they'd say, it's a pill that makes you pee.
Which is true.
It is true, technically. But the text gets into the molecular nitty-gritty. It says the primary mechanism for almost all of them is decreasing renal tubular sodium reabsorption.
Correct. And to really understand why that one phrase is so important, we have to talk about the currency of the kidney.
The currency.
Yes. In the economy of the kidney, sodium salt is money. The kidney spends a tremendous amount of energy, mostly in the form of ATP, just to move sodium from what's about to become urine back into the blood. It is obsessed with reclaiming sodium.
Why, though? Why is it hoarding all this salt? What's the point?
Because the golden rule of nephrology, water follows salt.
Osmosis.
It's pure osmosis. Imagine a crowded nightclub. The sodium ions are the popular celebrities. Wherever they go, the water molecules just follows them. They can't help it.
Okay, I like that analogy. So normally, the kidney acts like a bouncer, pulling the sodium celebrities out of the urine tube and putting them back into the VIP section, which is the blood.
A very energetic bouncer.
Sure.
And the water, the adoring fans, follows them right back into the blood.
So if you want to get water out of the body, let's say a patient has edema, they are swollen with fluid, maybe their heart is failing and their lungs are full of water, you need to trick the water into leaving.
You can't really grab the water directly. It's too slippery.
So you block the sodium from leaving the club, you keep the celebrities inside.
Precisely. You use a drug to lock the sodium inside the kidney tubule. If the sodium stays in the tubule, the water stays in the tubule with it. And eventually that tubule empties into the bladder, and it all leaves the body as urine.
So we aren't really pumping water out, we are just anchoring the salt, and the water is trapped with it.
That is the fundamental mechanism. We inhibit sodium reabsorption, which causes natriuresis, that's sodium loss, which in turn causes diuresis, water loss.
Okay, but not all diuretics are created equal. The source material breaks them down into these different classes based on where in the kidney they strike. And the first one is a bit of an oddball, osmotic diuretics. The text lists things like urea, sucrose, and mannitol.
These are the flushing agents. They work quite differently than the standard drugs. Most of the other drugs we'll talk about work like a key, jamming a specific molecular lock. They block a protein. Osmotic diuretics work by pure physics.
Physics? How?
Take mannitol. It's a type of sugar alcohol. You inject it into the blood, and because it's small, it passes right through the kidney's initial filter, the glomerulus. So now you have all this mannitol inside the tubule. But here's the catch. The tubule walls have no doors for mannitol. It cannot get back out into the blood.
It's trapped in the pipe.
It's completely trapped. And because it is a dissolved particle in osmole, it exerts osmotic pressure. Think of it like a sponge that's been thrown into the tubule. It just sits there and soaks up water, holding onto it. The kidney is trying its best to pull the water back into the blood, but the mannitol is holding onto it too tightly.
So the water has no choice but to just flow right through the system and out.
Exactly. It flushes the system. It's a very physical, brute force way of causing diuresis.
The text mentioned a real-world example of this that I think many listeners might recognize, even if they don't know the mechanics: uncontrolled diabetes.
Yes, this is a crucial concept. Uncontrolled diabetes is basically nature's own version of an osmotic diuretic. It's the same principle at work.
Walk us through that, because I know people with diabetes pee a lot, polyuria, but I never really understood the specific mechanics of why.
Well, normally your kidney is incredibly good at saving sugar. Glucose is valuable fuel for the body, so you filter it out of the blood, and the kidney tubules immediately grab every single molecule and put it right back in the blood. But, like a luggage belt at an airport, the system has a speed limit. We call it the transport maximum.
The luggage belt analogy is great. So normally the baggage handlers can grab every suitcase off the belt.
Right. But in uncontrolled diabetes, the blood sugar is so high, let's say over 250 milligrams per deciliter, that the suitcases are just coming down the belt way too fast. The handlers, the SGLT2 transporter proteins, are completely overwhelmed. They can't catch them all.
So suitcases start falling off the end of the conveyor belt.
Exactly. Glucose spills into the urine. And just like the mannitol we talked about, that excess glucose in the tubule acts like millions of tiny sponges. It sits in the urine and osmotically traps water. So the patient isn't just losing sugar, they were losing massive amounts of water that's being held hostage by that sugar.
And that's why they're constantly thirsty and constantly running to the bathroom.
That's the polyuria and the polydipsia. It's fascinating that the main symptom, the excessive urination, is actually just physics trying to balance an equation.
Everything in the kidney is balancing an equation.
That's the job.
Okay, let's move from the physical to the chemical. Let's talk about the heavy hitters, the loop diuretics. Furosemide, ethacrynic acid, bumetanide. Why do they get such a tough reputation?
Because they target the absolute engine room of the kidney, the thick ascending loop of hemo.
That sounds ominous.
It is powerful. This one section of the nephron is responsible for reabsorbing a massive chunk of the sodium, about 25% of the total filtered load. But more importantly, the way it does it is very specific and very complex. There's a particular molecular door here called the 1-sodium 2-chloride 1-potassium co-transporter.
Wow, that is a mouthful. Say that again. 1-sodium?
1-sodium 2-chloride 1-potassium. We just call it the NKCC2 co-transporter for short.
So what does that mean? It moves all of those at once.
Let's visualize it. Imagine a revolving door that requires 4 people to step in at the exact same time to make it spin. 1 person carrying a sodium sign, 1 person with a potassium sign, and 2 people with chloride signs. If they all step into their slots, the door spins and they enter the cell, getting reabsorbed into the body. Loop diuretics act like a boot on the wheel of that revolving door. They jam it solid.
So if one part is blocked, none of them get in?
None of them. The whole transport process grinds to a halt. And because this single transporter handles such a huge volume of solutes, blocking it causes a massive, and I mean massive, flood of fluid to stay in the urine. We are talking about urine output increasing to 25 times the normal rate.
25 times? That's not a trickle, that's a fire hose.
It absolutely is. That is why we use a drug like furosemide or Lasix in emergencies.
Yeah.
Picture a patient with acute pulmonary edema. Their heart is failing. Fluid is backing up into their lungs. They are literally drowning from the inside.
That sounds terrifying.
It is. They're gasping for air. They're panicked. You give them IV furosemide, and within minutes, the kidney opens the floodgates. It starts dumping fluid so fast that the pressure in the entire circulatory system drops, the fluid drains from the lungs, and the patient can breathe again. It can feel miraculous in the ER.
But surely dumping that much fluid that fast has a downside. It can't be that simple.
Oh, absolutely. It's a nuclear option. Remember our revolving door analogy?
The 4 people, yeah.
It also needed potassium to work. If you block the door, you aren't just losing salt and water, you are dumping huge amounts of potassium into the toilet. You can crash the patient's electrolytes very, very quickly. That's called hypokalemia, and it's dangerous.
The text mentions another reason these are so powerful, something about a countercurrent multiplier system.
Right. This is a bit more advanced, but it's key. The loop of Henle doesn't just reabsorb salt for the sake of it. It actively pumps salt into the deep part of the kidney, the medulla, to make it incredibly salty.
Why does it want a salty medulla?
Because later on, in the collecting ducts, that salty environment is what gives the kidney the power to suck water out of the urine one last time to concentrate it. It's the engine of concentration. So when a loop diuretic blocks that pump,
You break the engine.
you completely break the engine. The kidney loses its ability to make the medulla salty. And if the medulla isn't salty, you can't concentrate urine. So you impair the kidney's ability to concentrate or even dilute urine properly. It's a double whammy.
So it's a very powerful but very disruptive tool. Okay, let's dial it down. What if you don't need a fire hose? What if you just need, say, a garden hose? The text introduces thiazide diuretics.
Right. Thiazides, like chlorothiazide or hydrochlorothiazide, these are probably the most commonly prescribed diuretics in the world. They work further down the line in the early distal tubule.
And is that why they're weaker? Just the location?
Exactly. It's all about location, location, location. By the time the tubular fluid gets to the distal tubule, most of the sodium, about 90% of it, has already been reabsorbed upstream. The distal tubule only handles about 5 to 10% of the remaining load. So if you block the transporters there,
The effect is just naturally smaller.
much gentler. It's a different transporter, too.
Yeah.
It's the sodium chloride cotransporter. Simpler than the one in the loop.
So this is for your daily maintenance, not the emergency room.
Yes, exactly. These are often the first-line drugs for someone with just regular high blood pressure. You want to take the edge off their fluid volume over time, not dehydrate them in an hour. It's a much more sustainable long-term approach.
Now, there was a class here that seemed to involve a bit more chemistry. The carbonic anhydrase inhibitors. The text names acetazolamide.
This takes us way back to the very beginning of the tubule, the proximal tubule. And this is less about salt and more about acid-base balance, though they are linked.
Okay, time for a quick chemistry class. Carbonic anhydrase. What does that enzyme actually do?
It's a crucial enzyme. Its main job in the kidney is to help the body reabsorb bicarbonate. Bicarbonate, or HCO3, is the body's main buffer. It's like an antacid for your blood. It neutralizes all the acid your metabolism produces every day.
And the kidney's job is to save it, to recycle it.
Yes, but to reabsorb bicarbonate, it needs carbonic anhydrase to run the chemical reaction.
So if I take a drug like acetazolamide that inhibits this enzyme, I stop saving bicarbonate.
Right. You can't run the reaction. You can't reclaim it. So you pee out your bicarbonate. And here's the link to diuresis. Sodium likes to travel with bicarbonate. The technical term is sodium bicarbonate cotransport. So if you pee out bicarbonate, you pee out sodium and water too. So it works as a diuretic.
Yeah. There's always a but in the kidney.
Always. If you are constantly throwing away your body's main antacid, what happens to your blood?
It gets acidic.
Exactly. You develop what's called the metabolic acidosis. Because of that side effect, we rarely use this drug just for diuresis anymore. It's not very efficient. We use it for more niche things, like treating glaucoma, where it reduces fluid pressure in the eye, or for altitude sickness, where that specific chemical shift in the blood is actually helpful.
It's amazing how a drug's side effect in one context can be its primary therapeutic use in another.
It's all about understanding the mechanism.
Okay, the final class of diuretics directly addresses the danger you mentioned with the loop diuretics, the potassium loss. These are the potassium-sparing diuretics.
The name says it all. The goal here is to get rid of sodium and water, but we desperately need to hold on to the potassium.
The text mentions there are two different ways to do this. One involves a hormone called aldosterone.
Yes. Aldosterone is the body's salt-saving hormone. It's released when blood pressure is low, it travels to the kidney and essentially shouts the order. Grab every last sodium molecule you see, and to pay for it, throw away a potassium ion in exchange.
So it's a direct trade, save sodium, dump potassium?
It is. So if I want to stop that,
You block the hormone.
you use a drug like spironolactone or eplerenone. The technical name is a mineralocorticoid receptor antagonist. Basically, the drug molecule gets to the receptor first and just sits there. It blocks aldosterone from docking. It's like putting earmuffs on the kidney cells so they can't hear aldosterone's order.
So the kidney never gets the message, it doesn't save the extra salt, and importantly, it doesn't throw away the potassium.
Correct. You get a mild diuresis, but you spare the potassium. The other type, with drugs like amiloride and triamterene, is even more direct.
How?
They don't mess with the hormone at all. They go right to the very last part of the nephron, the collecting duct, and they directly block the sodium channel itself. It's called enancy. It's like putting a plug in the doorway. If sodium can't get into the cell has no reason to pump potassium out, so the result is the same. Potassium stays in the blood.
It really seems like all of pharmacology, or at least nephrology, is just a constant battle to balance these different ions.
It really is. You're always pulling levers. You pull the sodium lever down, but oops, the potassium lever moves too. So you have to pull the potassium lever back up, but that might change the pH. It's a delicate and sometimes dangerous art form.
So that's what happens when we manipulate the kidney. But what happens when the kidney just stops working? The text moves into section 2, acute kidney injury, or AKI. And the definition here really emphasizes the speed. Abrupt loss of function within a few days.
Yes. This isn't the slow decline of aging. This is a crash. It happens over days, sometimes just hours. And the crucial difference from chronic disease is that this is often reversible if you can identify and fix the cause fast enough.
The text categorizes this into 3 big buckets: prerenal, intrarenal, and postrenal. Let's start with prerenal. That just means before the kidney, right? So the kidney itself is fine.
The machinery is perfect, the nephrons are healthy, but the supply line is cut. This is almost always a blood flow issue. Severe heart failure, a massive hemorrhage, extreme dehydration from vomiting or diarrhea. For whatever reason, the kidney just isn't getting enough blood perfusion.
And there was a concept here that I found really counterintuitive. When the blood flow drops, the kidney stops making urine. It goes into oliguria or even onanuria. I just assumed that was because there was no fluid to filter. But the text says it's actually a deliberate survival strategy.
This is one of the most elegant concepts in physiology. It's the hibernation concept. You have to understand, the kidney is a very high-maintenance organ. It's metabolically active. It consumes a massive amount of oxygen per gram, almost as much as your constantly beating heart.
Why does it need so much energy? It's just sitting there filtering.
It needs that energy to run all those pumps we just talked about, especially the sodium pumps. Reabsorbing sodium is an active process that burns a ton of ATP. In fact, the kidney's oxygen consumption is directly tied to how much sodium it reabsorbs. If it filters sodium, it must spend energy to catch it again.
Okay, so if the blood flow drops and the oxygen delivery drops.
The kidney makes a calculated life or death decision. It says, I don't have enough oxygen to run the pumps. If I keep filtering sodium, I'll have to try and pump it back, and I'll run out of energy and my cells will die. So I will simply stop filtering.
It shuts down the factory to save the workers.
Perfectly put. It constricts the blood vessels that lead into the filter. The GFR, the glomerular filtration rate, plummets to near zero. By doing this, the kidney reduces its oxygen demand dramatically. The cells can survive on just a trickle of blood. The text says maybe 20–25% of normal, because they aren't doing any heavy lifting anymore. They're just staying alive.
That is an incredible piece of evolutionary design. It essentially plays dead to stay alive.
It is, but it's a gamble. Because if that blood flow drops below that basal requirement, or if it stays low for too long, even that hibernation strategy isn't enough. The cells begin to starve and die. And that leads us directly to the second category, intrarenal AKI, damage inside the kidney.
And one of the prime causes of this internal damage is what the text calls tubular necrosis, which is just a fancy way of saying the tubes die.
Right. If that prerenal ischemia, that lack of blood flow, goes on for too long, the epithelial cells that line the tubules die. And here's the really problematic part. They slough off. They just fall off the walls of the tubule.
Like peeling paint inside a pipe.
Exactly. And where does that dead tissue, that debris, go? It falls into the lumen of the pipe and clogs it from the inside. So now you have a physical blockage inside the microscopic tubes of the kidney. You get these muddy brown casts in the urine, which is literally just dead cells.
The text also mentions toxins as a major cause for this kind of internal damage, and it listed some scary stuff. Carbon tetrachloride, heavy metals like lead and mercury, and antifreeze, ethylene glycol.
Antifreeze poisoning. It's a classic board exam question for a reason. You drink it, usually by accident or tragically. Pets lick it up because it has a sweet taste, and the liver metabolizes it into toxic byproducts, mainly oxalic acid. These byproducts form sharp crystals. These crystals then accumulate in the kidneys and literally shred and kill the tubular cells. It's a direct poison that destroys the machinery from the inside out.
Wow. Okay, another intrarenal cause was listed as glomerulonephritis. This sounded like the immune system malfunctioning and attacking itself.
We often call this friendly fire. The classic story is a child gets strep throat, caused by group A beta streptococcus bacteria. The immune system, doing its job, makes antibodies to kill the strep bacteria. Great, right?
Sounds good so far. The immune system is winning.
But these antibodies latch onto little pieces of the bacteria and form these big, sticky clumps called immune complexes. These clumps are supposed to be cleaned up, but sometimes they travel through the blood and they hit the kidney's filter, the glomerulus. And because they're big and sticky, they get stuck.
Like trying to pour syrup through a sieve.
The perfect analogy, like gum in a sieve. And because they are immune complexes, they trigger a massive inflammatory response. The body sends its attack cells to destroy the complexes, but the complexes are physically stuck to the kidney's filter, so the immune system ends up attacking the kidney itself. The filter gets swollen, blocked, and sometimes so damaged that it starts leaking blood and proteins.
So that's prerenal, the supply issue, and intrarenal, the internal damage. The last one is postrenal AKI, after the kidney.
This is a straightforward plumbing blockage, but outside the kidney itself. A kidney stone getting lodged in the ureter, a tumor compressing the ureter, or in older men, a very common cause is an enlarged prostate gland squeezing the urethra shut.
I like the analogy in the text of putting your thumb on the end of a garden hose.
It works perfectly. If you block the exit, the ureter, or the bladder, the urine has nowhere to go. It backs up. This fills the collecting system of the kidney with fluid. That static fluid creates back pressure.
And that pressure pushes back against the filter.
Yes. Remember, filtration relies on a pressure gradient. The blood pressure in the glomerulus is high, and it pushes fluid out. But if the pressure in the kidney's plumbing rises to meet that blood pressure, filtration stops. It's a complete stalemate. Nothing can move.
So regardless of how you get there, prerenal, intrarenal, or postrenal, the end result is the same. The kidney stops working. What actually kills the patient in that acute setting?
It's a triad of killers, really. First, water retention. If you aren't peeing, you swell up. Your blood pressure skyrockets, you get generalized edema, and fluid can back up into the lungs, causing pulmonary edema. That can kill you.
Okay, so drowning in your own fluid.
Essentially. Second, acid. You can't excrete the acid your metabolism produces every day, so your blood pH drops. You get a severe metabolic acidosis. If your pH gets too low, around 6.8, you go into a coma and die. But the fastest killer, the real sniper in the room, is hyperkalemia.
High potassium. We keep coming back to potassium.
We have to. It is that important. The text notes that a potassium level of around 8 milliequivalents per liter can be fatal. Normal is about 4 to 5. So we are talking about what seems like a very small increase. It's only double the normal level.
Why is it so deadly? What does potassium actually do that makes this so critical?
It sets the electrical resting potential of all your cells, especially your heart muscle cells. The electrical stability of the heart depends on a very narrow range of potassium. If potassium in the blood gets too high, it destabilizes that electrical gradient. It prevents the heart muscle from resetting properly after a beat.
So the heart just stops.
It can go into a deadly arrhythmia like ventricular fibrillation, or it can just lead to outright cardiac arrest. It just stops beating effectively. That is why in any emergency situation, in trauma, in acute kidney failure, the first thing the doctor looks at on the blood work is the K plus the neg. You can fix the water later. You can give bicarbonate for the acid. You have to fix the potassium now.
That is absolutely terrifying. Okay, let's shift gears. We've talked about the acute crash. Now we need to talk about the slow fade. Section 3, chronic kidney disease or CKD.
This is a completely different beast. This is the progressive, irreversible loss of nephrons over months or more typically years.
And there was a concept here that I found really poignant. The text calls it the vicious cycle. It describes how the kidney tries to adapt to the initial damage and how that very adaptation is actually what dooms it in the end.
It is a physiological tragedy, and it's a theme we see in other organs too, like the heart. Let's say you lose 40% of your nephrons due to, say, years of uncontrolled high blood pressure. You now have 60% left. Those survivors don't just clock in and do their normal shift. They recognize there's a problem. They step up.
They hypertrophy. They get bigger.
Yes, they physically get larger. They dilate the blood vessels leading into them to accept more blood flow. They increase their individual filtration rate. They work overtime, 247, to clear the same amount of waste for the whole body that all the nephrons used to handle.
Which sounds heroic. It sounds like a good thing.
It is heroic, and in the short term, it works. Your blood work, your creatinine levels might look completely normal. You feel fine. The survivors are carrying the extra load. But think about what happens to a car engine if you run it in the red line at maximum RPM constantly.
It burns out. It blows a gasket.
Exactly. The high pressure and the high flow rate required for this superfunction eventually damages the delicate, fragile structures of the glomerulus. They scar over. The medical term is glomerulosclerosis.
So the supernephrons literally die from overwork.
They burn out and scar down. And now you have even fewer nephrons left, say only 30%. So the remaining few have to work even harder. Their individual filtration rates go up even more. which of course makes them burn out even faster. It's a death spiral. Once you cross a certain threshold of nephron loss, the kidney is doomed to fail, even if you completely cure the original disease that started the problem. The compensation mechanism itself destroys the organ.
That is just heavy. It's like a labor shortage where the remaining workers are praised for their hard work and then worked to death until the whole factory has to close down.
That is a perfect and tragic analogy for what happens.
The causes listed in the text are the usual suspects we hear about all the time: diabetes and hypertension.
They make up the vast majority of cases. The text says diabetes accounts for about 45% of all end-stage renal disease. Hypertension is the second leading cause, at about 27%. And of course, obesity is a huge risk factor for both of those.
The text also mentions vascular lesions, like atherosclerosis, and a term called benign nephrosclerosis, which is apparently just aging.
Yes. Benign is a bit of a misnomer. It's a medical term that just means it probably won't kill you fast. As we age, our arteries everywhere get stiffer and narrower. This happens to the small arteries in the kidney as well. We gradually lose nephrons. The text says it's found in 70% of autopsies of people over 60. By age 80, your kidney function can be half of what it was at age 30, just from normal aging.
But because we have so much reserve capacity, so much redundancy, most people don't even notice.
Exactly. Your remaining nephrons hypertrophy and compensate, and you live your life just fine. The problem is when you add another stressor like diabetes or hypertension on top of that age-related decline. Then you run out of reserve much faster.
There was another cause I wanted to touch on: interstitial injury, specifically pyelonephritis. This is a bacterial infection.
Yes, this is a kidney infection. It's usually caused by E. coli bacteria from fecal contamination that travels up the urinary tract.
So it starts lower down.
Right. It typically starts as a bladder infection or cystitis. The bacteria ascend from the bladder, up the ureters, and into the substance of the kidneys, where they can cause inflammation and scarring.
And the text mentioned a specific condition that makes this more likely: vesicoureteral reflux.
Yes, this is an anatomical problem. Normally, when your bladder contracts to urinate, the way the ureters enter the bladder wall causes them to be pinned shut. It's a natural one-way valve.
So urine can't go backwards?
Exactly. But in some people, especially children, that valve is incompetent. So when they urinate, the high pressure in the bladder forces urine and any bacteria in it backwards up into the kidneys. This can lead to recurrent infections and chronic scarring over time.
Okay, before we move on, I want to clarify nephrotic syndrome. The text separated this out as a distinct problem. It's characterized by massive protein loss in the urine.
This is a specific type of glomerular failure. Normally, the glomerulus is a very fine sieve that holds back all the big things, like blood cells and proteins. In nephrotic syndrome, for various reasons, the holes in that sieve get too big. They start letting albumin, the main protein in your blood, leak through into the urine.
And this causes severe edema, but not because of the usual salt and water retention.
Correct. This is physics again, but a different kind. Albumin in your bloodstream acts like a magnet for water. It creates what we call colloidal osmotic pressure or oncotic pressure. It's what holds water inside your blood vessels. If you start peeing out all your albumin,
Reduce the magnet.
you lose the magnet. The water is no longer held tightly within the blood vessels, so it leaks out into the surrounding tissues. The patient becomes incredibly swollen with full-body edema, not because they have too much water, but because their blood literally cannot hold on to the water it has.
It's amazing how many different physiological paths lead to the same symptom of swelling up. Okay, section 4. Living with failure. The physiology of the failing kidney. There is a word here I had never seen before: isosthenuria.
It's a great cocktail party word for nephrologists. It means urine of the same strength.
And what does that actually mean for the patient?
It means the kidney has lost the ability to concentrate urine and the ability to dilute it.
It's stuck on one setting, like a broken thermostat.
Exactly like that. Remember our supernephrons that are working overtime in chronic kidney disease? The flow of fluid through those remaining tubules is so fast, it's like a rushing river, that the delicate mechanisms that normally concentrate or dilute the urine just don't have time to work. The countercurrent system fails.
So the urine comes out at whatever concentration the blood plasma was to begin with.
Precisely. The specific gravity of the urine becomes fixed at about 1.008, which is the same as the glomerular filtrate. The kidney is no longer a regulator, it's just a passive pipe. This is a huge problem. You drink a gallon of water, you can't make dilute urine to get rid of it quickly, so you become fluid overloaded. If you're lost in a desert, you can't make concentrated urine to save water, so you dehydrate very fast. You're completely at the mercy of your fluid intake.
The text also lists the effects of uremia, the toxic state of kidney failure. We've talked about the edema and acidosis, but the one that really surprised me was the effect on the bones. Osteomalacia. Why does kidney failure break your bones?
This is one of the most critical and, I think, overlooked functions of the kidney. The kidney is the organ that activates vitamin D.
I thought we got vitamin D from sunlight or from drinking fortified milk.
You do, but the vitamin D you get from those sources is inactive. It's a prohormone. It's useless in that form. It has to go to the liver for one chemical step, and then, crucially, it must go to the kidney for the final chemical stamp of approval, a process called hydroxylation, to become active vitamin D.
So if the kidney fails, no stamp of approval.
You have no active vitamin D. And without active vitamin D, your intestines cannot absorb calcium from the food you eat. You can drink all the milk in the world, the calcium just passes right through you and out.
Which means your blood calcium levels would start to drop.
Yes. And the body hates low blood calcium. It is an absolute emergency because it's critical for muscle contraction and nerve function, especially for the heart. So the parathyroid gland in your neck panics. It senses the low calcium and releases PTH, parathyroid hormone.
And what does PTH do?
PTH is a scavenger.
Yeah.
Its one and only job is to find calcium anywhere it can and get it back into the blood to keep the levels normal. And the biggest storage depot of calcium in the body is your skeleton.
So it dissolves the bones to save the blood calcium.
It literally strips the calcium right out of them. It's robbing Peter to pay Paul. It demineralizes the bones to keep the heart beating. Over time, the bones become weak, brittle, and prone to fracture.
That is just brutal.
It actually gets worse. Failing kidneys also can't excrete phosphate. So phosphate levels in the blood go up. High phosphate binds to calcium, taking it out of circulation and lowering the free calcium level even further. So you have this double whammy, low calcium absorption and high phosphate, both screaming at the parathyroid gland to dissolve the bones. Patients with end-stage renal disease can have bones so weak they fracture just from walking across a room.
And on top of all that, they're anemic. Why anemic?
Another vital hormonal function. The kidneys produce a hormone called epoerythropoietin. It's the hormone that signals the bone marrow to produce new red blood cells. No kidney function, no EPO, no new red blood cells. The patient becomes profoundly anemic. It really shows you how the kidney is central to the skeletal system, the endocrine system, and the hematopoietic system. It's not just a filter.
Okay, we've covered the big diseases. But Section 5 takes a fascinating detour into the weird stuff. Specific tubular disorders. The text calls them glitches in the kidney software.
These are nature's experiments. These are usually rare genetic conditions where just one specific transporter or channel is broken. They are incredibly educational for scientists because they create a perfect model that proves exactly what that one broken part was supposed to do.
For example, the first one listed is renal glycosuria.
This is a totally benign condition where the glucose transporter in the proximal tubule is defective, so the patient pees sugar constantly, but their blood sugar is completely normal. They don't have diabetes, they just have a leaky pipe for sugar. It proves that that transporter's only job was to reabsorb glucose.
Then there's nephrogenic diabetes insipidus, which has a really confusing name.
It has nothing to do with sugar diabetes. Insipidus means tasteless. In the old days, doctors would actually taste a patient's urine to help with diagnosis.
I am so glad we have modern labs now.
Me too. Diabetes mellitus sugar diabetes urine tastes sweet. Diabetes insipidus urine tastes like water. In this condition, the kidney's collecting ducts are unable to respond to ADH antidiuretic hormone. ADH is the body's main save water signal.
So the kidney is getting the command to save water, but it just can't hear it. The radio is broken.
Exactly. The receptor for ADH is broken. So the kidney dumps water constantly, no matter what. The patient is incredibly thirsty and produces huge volumes of very dilute urine, up to 15-20 liters a day, even if they're severely dehydrated.
There were two syndromes here that sounded like the diuretic drugs we discussed earlier, Bartter syndrome and Gittleman syndrome.
These are absolutely fascinating. Bartter syndrome is a genetic mutation that breaks the exact NKCC2 transporter in the loop of Henle, that loop diuretics block.
The 1 sodium, 2 chloride, 1 potassium thing.
That's the one. So a person with Bartter syndrome functions exactly as if they are on a high dose of furosemide every second of their life from birth. They have low blood pressure, they lose salt, and they have dangerously low potassium.
And Gittleman syndrome.
Same exact concept, but it's a mutation in the sodium chloride transporter in the distal tubule, the one that thiazide diuretics block. So it's like taking a thiazide pill forever. Again, low blood pressure, low potassium. They're nature's version of diuretic overdose.
It's finally Little syndrome. This one sounded like the complete opposite of the others.
It is. It's sodium channel overdrive. The ENSC sodium channels in the collecting duct are mutated, so they are stuck in the open position. They never close.
So they're constantly reabsorbing too much salt.
Massive amounts. The patient acts like they are on a salt overdose, 2047. They retain huge amounts of salt and water, leading to severe early-onset hypertension. But what's really interesting is that if you measure their aldosterone levels, they're practically zero.
Because the body's desperately trying to shut the system down.
Right, the body's screaming, stop saving salt. But the channels are mutated and jammed open. And the treatment, brilliantly, is amiloride, the specific potassium-sparing diuretic that blocks those ENSC channels. It's the perfect molecular key for that specific broken lock.
I love when the mechanism of the disease matches the cure so perfectly. All right, we have arrived at the final section. Section 6. Artificial solutions. The kidneys have failed. The death spiral is complete. What do we do? Dialysis and transplant.
These are the life support systems for end-stage renal disease.
Let's talk about dialysis first, the artificial kidney. I know people spend hours and hours a week hooked up to these machines, but what is physically happening to their blood?
It's all based on the simple principle of diffusion across a semi-permeable membrane. We take the patient's blood and run it through a filter that contains thousands of tiny hollow fibers. On the outside of those fibers, we flow a special liquid called dialyzing fluid, or dialysate.
And the magic is in the recipe for that fluid.
The magic is entirely in the recipe. Think of it like making tea. The tea flavor diffuses out of the bag into the water, but the big tea leaves stay inside. In dialysis, we want to remove the waste flavors, the urea, the creatinine, the excess potassium. So the dialyzing fluid we make contains 0 urea and 0 creatinine.
So nature hates a vacuum. The urea sees 0 on the other side and rushes out of the blood into the fluid to balance things out.
Correct. But here's the clever part. We don't want the patient to lose their sodium or chloride. We want those to stay at a normal level. So the dialyzing fluid is made with the exact same concentration of sodium and chloride as healthy blood.
So there is no gradient for them to move.
No gradient, no net movement. The salt stays in the blood where it belongs. We can even reverse problems. To fix the patient's acidosis, we put extra bicarbonate in the dialysate so it diffuses into the patient's blood. It's incredibly elegant.
That is smart engineering, but the text makes it clear it's not a perfect replacement.
No, not even close. It's a part-time job trying to do a full-time job. Normal kidneys filter your blood 24 hours a day, 7 days a week. Dialysis happens maybe 12 hours a week total. It cleans the blood, but only partially, and the waste products build up again between sessions. And crucially, it cannot replace the hormonal functions. It doesn't make EPO or activate vitamin D without extra medications.
Which brings us to the gold standard, transplantation.
The only true cure, a new kidney. And the amazing thing about the kidney is its redundancy. One single healthy kidney is more than enough to do the job perfectly. It restores everything, the filtration, the reabsorption, the EPO production, the vitamin D activation. It's a complete system reset.
But the hurdle is the immune system again, just like with the glomerulonephritis we talked about.
Rejection. The body's immune system is designed to identify and destroy anything that is not self. It looks at this new kidney and says, that's not mine, and it launches a full-scale attack. So patients have to trade one disease for another. They trade kidney failure for a lifetime of immunosuppression.
Meaning they have to take powerful drugs that weaken their immune system, making them vulnerable to infections and even some cancers.
Yes, it's a significant trade-off. But for most patients, the freedom from the dialysis machine, the restoration of energy, and the ability to live a more normal life is absolutely worth that risk.
We have covered a massive amount of ground today, from the celebrity sodium ions in the nightclub to the tragic, heroic death spiral of the last few nephrons. What is the big picture takeaway for you from all of this?
You know, we started by saying the kidney is just a filter. I hope we've proven it's so much more. For me, the takeaway is the incredible fragility of the balance. We saw how a simple thing like a strep throat infection or a few days of low blood pressure after an accident can spiral into a total system collapse. It's a high-wire act every minute of every day.
And the irony of the body's own compensation mechanisms really stuck with me. That idea that the body tries so hard to save you, the heart pumping harder against high pressure, the nephrons filtering faster to clear waste, that it actually destroys itself in the process.
It's a profound lesson in physiology and perhaps in philosophy. The short-term fix, the heroic effort, often guarantees the long-term failure. We see it in kidney disease, we see it in heart failure. It's a recurring tragic theme.
And I'll leave everyone with this final thought. The next time you drink a glass of water, Just take a second to appreciate the master chemist working silently in your lower back, this high-frequency trading computer that's balancing acids, bases, salts, and pressures, all just so you can stay alive to listen to this deep dive.
And maybe drinks a little extra water while you're at it, just to make its job a tiny bit easier.
Sound advice. Thanks for diving deep with us.
A pleasure.
See you next time.